Yeah. Yeah.
Yes, sir. We can see you, sir.
Yeah. Okay.
Yeah, yeah. So thank you so much, sir, for
Yeah.
taking the
Sorry.
time from your busy schedule and joining with us. And like, yeah, giving your consent to talk something in our particular objective. So, participants, it's my pleasure to introduce Dr. Jyotisman Sakia, who is currently working with AIMS New Delhi, as you all know. She is currently working with Department of Surgical Oncology at AIMS New Delhi and National Cancer Institute AIMS Jhajjar. His area of interest lies in breast oncology, thoracic oncology, artificial intelligence, and he has hold several honorary positions like convener thoracic oncology, ambassador EARC. He has published several research papers in international journals and conferences, and he's also a reviewer of International Journal of Cancer. He is also involved with several research projects in the capacity of PI as well as co-PI. So with this, now I request you to please start the session. Over to you, sir.
Okay. Thank you so much. I express my regards, and I really thank Dr. Deepak Nayak from MNIT for giving this opportunity. Can I share my slides? Should I share the screen here?
Yes, sir. There's a share
Okay.
button, sir.
Okay. Okay. Just let me know if you can see my screen.
Yes, sir. It's visible, sir.
Okay.
Yes.
Okay. Thank you. So, so I bring greetings from the All India Institute of Medical Sciences, New Delhi. These are the two campuses of AIMS Delhi where I work with ISCH and the National Cancer Institute. So this is my disclaimer. Like oncology and itself is a, as you all know, that it is a quite a wide area of uh, medical science, and with increase in more of medical science technology in oncology, basically. So technology is also moving hand in hand. So while we need to collaborate, like it's a very interesting area of exercise today, what we are doing. See, cancer surgeons or oncologists as a whole, they work on biology and or surgery, to be specific in my area, while engineering works in it quite a different aspect to start with, like devices, data, AI. So while you see that there is a, while we go through the session, we will know that what are the areas where we actually need to work upon. So cancer surgeries are actually complex, and they are quite resource intensive, where it is a matter of life or death mostly, while the long surgeries where there is where which can be sometimes which the resources are not adequate to actually deliver the service we want. So many areas where surgeons have started to use robotics now, but it was without that, while robot was there in engineering many years, decades back. So like intraoperative navigation, what we do, the radar or whatever technologies which engineers use, those most of the technologies were not used in medical science, in surgery specifically. So with time, this has been realized that although lately that why if we can use them, collaborate them, then probably we can do much better work with less resources, and that is where we are today with this discussion. So to bridge this gap, So if we need to know the what is the burden of problem we are discussing about. The it's a, India is a huge cancer burden with 1.4 million new cases like lung, breast, cervix, and these are the GI cancers are such major dominating the main bulk of cancers. And so our the Indian Council of Medical Research has recently published a trend what is expected is by 2035 and 2040 our volume of cancer patients would be very high, and it is I think there's a projected score by 2045 to be going to be doubled. So India has a wide range of cancers all across the country, and there are many reasons to that. This is okay. The etiology can be starting from smoking and food and occupational and many more. So 50% of all solid cancers, actually surgery is required at some point of time. The numbers are even more, it may be 60, 70%. So there's an increase in interest in organ preservation to do more close surgeries to preserve as much as possible and improve the patient's function and do smaller incisions. So that is where the minimal invasive, usually the laparoscopic surgery you might heard of, and now the robotics. So small incision to do a big surgery, which can decrease the morbidity of the patient and improve the quality of life at the same time and better care. So, but these are the all technology demands. So a better a laparoscopic machine, a more resolution camera and 3D vision, and then robotics. So these all are actually a technology driven field, which is actually pushing and helping to reach a better cancer care. So as we come to know that we are not separate, but it is very much interlinked. There are energy sources are used to cut previous days at the when the start of surgery we used caught a knife and um, to tie a vessel we use threads. But with time the technology use of staplers have come into action, and like energy devices like sealing devices. Uh, we as engineers are used to sealing with metal like coagulation and all this. They are used to that sealing to wires and to areas. This has been done quite often. But in surgery, sealing a blood vessel or stapling ends of an ostomy, those are very which seem to be very modern, unlike engineering field. So because these are recently developed, they are very demanding, and many of the is technologies, most of them we import from abroad, and so hence their costs are very high, and it is not easily accessible to all most places in the country. So it's limited to very like tier one cities or big corporates. So one thing is clear that use of technology is definitely is going to is advancing our care, the quality of care, quality of surgery specifically. But the access to this technology and not only access but affordability also at the same time are things which we need to work upon, because with the increased cost, the treatment cost also similarly increases. So, so technology can for surgical oncology for surgery like there are three areas if we divide in three areas like pre-operative like before surgery and during surgery and after surgery can divide in 3 years where technology can help oncologists. So this is a brief one, like just to say that in the AI imaging, like preoperatively CT scan, MRI, and mammography, all these are done. So AI imaging is where we can easily detect what is the area of cancer we're talking about. Like, for example, you must have heard about there are many software companies who are doing computer vision analysis, AI companies who are doing this for chest x-rays to see that in the chest x-ray whether there is some lung diseases there or not. And there are some companies who are looking into the fractures, x-rays, and looking into fractures and whether the AI can detect fracture automatically or not before the doctor can report. So for example, one doctor can report 100 x-rays per day. So with the use of AI can report more, thousands, many thousands of x-rays per day. So that is where technology is developing. Google is also working on mammography, like based on the mammography, if you feed the mammography, it can tell whether the patient is having breast cancer or not. So AI imaging is coming in a big way, and many companies are there are many startups in India who we met, we often come across, who are also trying to develop this type of technology. For example, in dermatology, images, looking at the images, scanning the images, can say that whether the patient has what type of problem he or she has and what would be the treatment. So and same is what is coming up in pathology, like biopsy slides. You don't require a pathologist, and so slides once done, they will be scanned and the image will be read by AI. So this is what is coming up in the future. For surgery, like simulation, like before operating the patient, we'll come across this one in the next few slides, and 3D modeling also. And similarly, in intraoperative setting, as I told, robotics. Use of robotics has come up in a big way, and which is actually helping surgeon to go for long surgeries. Like there are my cancer surgeries sometimes go for 8-10 hours. So you can't imagine like standing in the operation theater for many hours. uh, by the end of third, fourth, fifth hour, as the surgeon keeps moving towards the other end, he or she will start feeling very tired. His legs will tremble, and then he or her hunger. There will be a person remains hungry for 3-4 hours, 5 hours with intense exercise. You can imagine how hungry they will be. So you are not doing a daily routine walk, you are hungry, thirsty, and you feel like going to the loo, and all these are happening within that 7-8 hours, and you were stuck because you were scrubbed. Patient is under anesthesia, and you have kept the abdomen open, and you are looking at the time like how fast I can complete the surgery because patient is also already under the anesthesia. You are scrubbed in your gown, and it is a relatively a massive field. Not only you, there are three or four more surgeons. Your assistants are also scrubbed, and everybody's standing and the OT and just going on. So imagine like you are sitting in a robot, and then you are operating. You are not scrubbed. You have not changed you are in your office dress, and you are just operating. You are thirsty, you can take a drink, you can relax. So the quality of surgery obviously improves, and besides that, the surgeon's quality of life improves. Like there are many incidences where workplace hazards, like surgeons standing for many hours, develop a cardiac arrest. uh, Not to mention about lower limb deep vein thrombosis and varicose veins and many more, back pain and all this. So there are many areas where this robotics is coming up. Besides, the major benefit is like going into the deep cavities, doing surgery where open surgery is very difficult to reach, you are developing mild tremors, the robot can nullify those tremors and go help you to do a smooth surgery. So besides the advantages for the surgeon's mindset, the longevity of the surgeon, and so that is where robotics can actually go a very long way. So having said that, robotics, as I already said, I mentioned that robotics was developed, came to surgery very recently. So uh, like the current robot price is around 20-25 crores. So you can imagine such a hefty price, and then you are doing operation on a patient, you will obviously, the cost of the same surgery will go shoot out for 3-4 times higher than open surgery. So similarly, so there are few other companies like who have their 2-3 more companies who have come up with their robots, which cost is came down to around 16 crores. So but India is in India there is one company called as Mantra, which has developed a robot which is around 4 or 5 crores. So you can see that if we can develop an indigenous such type of machines, and by saying the machine, I don't want to mean the hardware, as you might be able to understand that hardware, there are better hardwares people have developed for engineering purpose, like robotics is much advanced for that. But for the hardware is not a big problem in robot. That it is a software which actually is stealing the game. So you must be knowing better. So this is where technology can help to develop that. Same as a real-time navigation. So and sensors, like you are doing a surgery using a robot or something, then but you are not able to touch the patient, so you don't feel what is the softness, what is the hardness of a particular area or organ using the robot. So then sensors, developing a sensor which can make you feel the same can help to actually improve your surgical outcomes. So in a post-operative setting, like recovery and tracking, like how the patient is getting recovered, whether the patient is having some during the post-operative period, like after the surgery was done for the next 24 hours, whether the patient is having some um, minor problems or any major problems, like which you can track. Like now what we do is that a human is tracking, the nurse is tracking every for 2 hourly pulse, BP, temperature monitoring is done, and other parameters are monitored. But if you can develop a tracking monitor, there are many companies have come up with this, but still, so you can develop something which can monitor the whole patient's outcome for the next 24 hours, 48 hours, and give the concerned team a understanding that based on these parameters, I feel that the next few hours this patient might go for might develop some stroke. So that is a prediction. Risk prediction can also be done, like after during the post-operative period, which patients are more likely to have some problem. Same is the data analytics and audits. So as I said, well, let's discuss a simple case of virtual simulation and augmented reality. This is one of the project actually we are working on. So you can see here that this is the doctor and who is, and this is a patient. So what happens is that the patient is in front of you, and now you're going to operate the patient. But as you know, the practice makes you more better. So many times as surgeons are learning, like I have learned from my senior, and similarly there's a trend of learning. I have learned while I'm sitting standing with him, assisting him in the operation theater. Now when I'm operating the patient, so surgery is actually a one-time job. Like if you have cut one area, you cannot recut it or seal and recut it. So this is a one time. So what happens in virtual reality is that you take the virtual patient, the whole the patient's whole body is scanned, and then you create a virtual patient just like a digital twin, and then the surgeon will operate on the patient virtually, like for example a gallbladder. And then you can see here, like for example this is a green structure, the gallbladder. So and then you cut the gallbladder, cut the vessels, and there will be bleeding, there will be bleeding. You know that you have done in this step, you used a wrong incision or wrong probe step, and there is some bleeding. So you will know what incision, what step has gone wrong. And this you can do practice 2-3 times or many multiple times before actually going to operate on the real patient. So mind it that the patient's anatomy actually varies from one patient. There is some bit of variation happens from patient to patient. Some patients are fat, some thin, some bit of structural anatomy also varies. So using this technology can be more confident in doing complex surgeries. That is what is the aim. And so for that we need to have we have an objective to do. There is a collaborative model between technology institutes and a cancer center, and a plan. And there will be the key our surgeries to begin with, where we can start our first program and do a annotate the images and do all the steps necessary to, and followed by the testing and validation and final product. So let's take another example like 3D scanning and reconstruction. For example, many times patients undergo breast surgery. So there is on the right side of the patient, you can see that the breast is removed, breast was removed. And so that means the patient has undergone a mastectomy following breast cancer. So the 3D scanner will now, the patient wants to get reconstructed her breast, or patient may want to develop a prosthesis similar to her left breast. So what comes, if you see that what we do currently is that we measure the other breast with the old style, the tapes and other things, the measuring tape and all, and then we do a reconstruction measurement of the on the right side of the breast, where we need to actually reconstruct the breast, and then we use some other tissues and all to reconstruct based on the size of the existing breast. So what the 3D scanner will do, it will scan the breast on the left side, on her left side, and then it will provide all the coordinates we need, and then based on that coordinates it will help to identify like what would be the reconstruction like in the right side. And similarly, if the patient wants a prosthesis, right now what happens is there are the various sizes of prosthesis comes, like a small, medium, large, based on it's not very patient customized. So with the 3D scanning can create a customized prosthesis. As you can see in this case, a customized prosthesis can be created which can just mimic like the left or the other breast. So these are simple examples of where we can use the AI. So I'll just give you a list of items. We will not discuss them in the interest of time, but probably you can go through this as an area of interest. Like, for example, in the pre-operative, before operation, some of the things which you can do is a tumor localization and visualization using AI-based 3D reconstruction. We have discussed already. The predicting response to neoadjuvant therapy, the radiomics and pathomics, which have come up in large scale right now. And then personalizing surgical extent, like AI models analyzing the tumor to breast ratio. This is what we are also working on this. Distance from landmarks to suggest the breast conservation versus oncoplasty. So, and patient risk stratification, like multimodal AI classifiers are there to combine different probable risk factors and trying to predict the risk of the patient following at the point of diagnosis. During the operation, some of the areas where AI can help is like intraoperative margin assessment. the real-time AI image processing from fresh frozen section. We are now procuring a machine for this the intraoperative margin assessment. So this is developed by one of the European companies. So what they have done is that you get the tissue directly from the margin and put it on a slide, and then with minimal staining, and you can put it into the in the camera in the device, and then it will scan. It will do a CT scan type of thing, if layer by layer on the tissue. We don't need to crush it, don't need to slice it, and then it will do layer by layer scanning, and it will provide the images for reporting. So that is a very excellent idea to do it. Maybe we can also think of developing something on that lines. Navigation and in anatomically complex regions like integrated navigation and optimizing robotic assistance, we already discussed that. AI guided decision support like live intraoperative decision search engine and or solution engines, like if the diagnosis is there, then what should be the treatment. There are many companies who are also working on, and some of them in India as well. In the post-operative setting, like surgical skill assessment, like AI-based video review system, like how to assess the skill of learning trainees, training surgeons, and the post-operative complication prediction on like predictive models, wound healing and symptom tracking, like chatbot or something which can monitor the post-operative wound and then assess that whether this patient is going to develop infection in next few days or not, and then uh, intervening early intervention can be done. And quality of life prediction also, these are other. Then system level AI integration like multidisciplinary tumor board planning, data fragmentation in hospitals, like enabling integration of various EMR packs and other data, and then unifying dashboards, and then predicting the treatment outcomes, and also in triaging, remote triaging, and teleoncology. So having said so many things, like how technology institutes can participate, they can buy hardware prototyping, AI, ML development, software systems, assistive tools, and many more, which you can imagine of. So there are some common barriers to uh, such type of collaboration. Like there is a language divide. Like what I as a surgeon will ask for, like I want, like is this machine should this device should compress the tissue only this much. I don't want much compression. The way I express my ability to express the technology partner, that is where is the main one of the biggest problem. I'm unable to express because I don't understand engineering knowledge. I have little knowledge on that. And similarly, when I express my problem in medical knowledge, the engineering side, they find it difficult to understand the medical part. So there's a language barrier is there, where that is where it took so many decades to actually come technology to dive in medical science. Besides that, there are other common issues which are like the IP rights and data privacy, which is actually a very big concern. More concerning than IP rights is the data privacy. So patient data is very much private, and we cannot disclose it without their consent. And that is where a big problem comes in, like data sharing between institute, like transferring patient data to another institute. And of course, to solve this, there are many institutes who has come up with the idea that their technology people will uh, come into the campus of the other medical institute and create a small hub there and work there itself for majority of the data which cannot be transferred. Some part of data which is anonymous can go to the transfer category. So other big thing is funding and sustainability. So how to build synergy is by co-creation of teams, joint funding applications. Yes, there are many funding agencies like ICMR, BIRAC, and DVT, and many more, which start, but this is a very huge competitive program, and there are so many good proposal keeps coming, so it becomes a tough uh, time every time. That is not so easy, but yeah, that is one of the opportunities. And other option is a pilot studies before doing some scale up and academic publication, and to build up the preliminary work for applying for such big grants. So there are institutional support is also required, like at AIMS, like NCI, we have built up the Center for Medical Innovation and Entrepreneurship, where we are inviting many companies, technology companies, to incubate and start working together uh, there. So this is one of the this is where the Center for Medical Innovation Entrepreneurship is a joint project developed by BIRAC and AIMS, and it is established at National Cancer Institute. The main office is there. So we have a big lab with many spaces where the technology partner are incubated for developing common projects for common goals. So that is what is the vision for future, and a call to invite and collaborate. This is my team of our faculties, and these are our residents who have been working with us for with a lot of time. Thank you very much. Thank you for the opportunity. You can contact. This is my email, and for any project related, you can contact me. Thank you very much.
Yeah. Thank you, sir, for your informative talk. I mean, you have just now mentioned that how to, I mean, where AI can be used, right? And also you have talked about the gap. I mean, the basically the gap between the technology and the clinical side. So,
Yeah. Any
uh,
questions we can take up? Otherwise, thank you very
yeah,
much.
uh, participants, if are having any queries, they can only write their queries in the chat box, sir.
Yeah. If yes, then we can discuss. Otherwise, you can send me mail, and we can discuss over mail also.
Yes, sir. So let us wait for 1 minute.
Yeah, sure. No worries.
Uh,
But
they
it's a
can.
nice program. Actually, I really appreciate such programs. Would be really helpful for good collaboration, actually. And I really appreciate Dr. Deepak for organizing this. Actually, we need more of such type of collaboration. Like, so we can understand each other better. And
Yeah.
maybe,
Thank you so much, sir.
yeah.
So any queries, participants, if you're having, uh,
You can also send me in my mail anytime, so we can directly discuss that also.
yes, sir.
Now technology has come up in a big way, and actually that's driven by the West, actually, like other areas. So we don't have much option at this time. Like, if we want to improve our medical services, we have to procure at a paying a hefty cost, and to bring the same standards of surgery here. So right now, in India, we are doing this almost the same standards and even better surgery than many Western countries, because we, not in every, but in many of the cancer centers, like the big ones, they have all the technology almost, what you can imagine, whatever is available globally, almost. So technology wise, you shouldn't fall apart. Then only there's a balance and competition with equal and both sides. So that is why I think it is very important that we keep up with technology, and we start developing ours also. So, just like China has been developing everything their own almost.
Yes, sir. Uh, no problem, sir. I mean,
Yeah,
participants, if you're having any queries, so I mean, you can just directly drop an email to sir. So sir
yeah.
will reply you back if you're having any queries regarding collaborations, probably some of the problem statements statements, whatever sir has discussed. I mean, he has shown us a lot of directions where AI can be useful in
Yeah,
clinics.
yeah,
So, I mean, yeah, any problem could be, I mean, we can just pick up any of the problems and they can start working on it.
yeah. So okay.
Okay,
Then
sir.
thank you. Thank you
Yes, sir.
very much.
Thank you
Thank
so much, sir,
you.
for
Thank
joining
you very
us and
much.
sharing your expertise. Thank you, sir.
Thank you
Thank
very
you.
much.
Thank you, sir. Okay, so participants will move on to our next session in a few minutes. Right. Our next speaker is Professor Niladri Puhan from IIT Bhubaneswar.